The information presented is in no way to be considered as a standard of care, and the content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The information is provided with no guarantee. All content is for informational purposes only and does not constitute the providing of medical, legal, or regulatory advice.
Hey everybody, welcome to this edition of Blue Crew Medicine. This morning we've got Emily Wells and Lauren Russell, two of our neonate nurses. We're here to talk about a little bit about neonates and babies and how you take care of them, some of the basics. We're not going to go too far down a rabbit hole, hopefully, although knowing us it could very easily. Mm-hmm. So we're going to talk a little bit about neonates. So defining a neonate is 28 days or less. Anything else you want to add to that besides just the basic definition? Y'all take care of these things every day. Been doing it for how long now?
12 years. 12?
11 for me.
No, then that's not right for me. Yeah. Then I'm 10 years.
So when we talk about babies, a lot of people get really nervous when they see, okay, we're going to have an at-home delivery, or they're delivering in an outside hospital doesn't have a NICU, or doesn't have a neonatologist, doesn't have a pediatrician, somebody trained to take care of babies. Mm-hmm. Everybody gets really, really worried about the baby itself and everything else. Biggest thing, or one of the biggest things I wanted to make sure we talked about this morning, is most babies are fine. Most babies don't need a whole lot.
Yeah, they are. Less is more. Less is more. It's always going to be our motto with babies. Like, yes, we do know how to do all the codes and all the things and resuscitate when they really are truly devastated, but the likelihood of actually having to do that is very small, and truly less is more with these babies. If you know the very basics of them, all these babies are going to be okay.
The other thing I wanted to mention is a lot of people will get harped on all these certs and having NRP and all this other stuff. NRP doesn't change. Now, there's a couple things we're going to talk about, but NRP really hasn't changed in several years. So if you don't get an opportunity to get it, because it's kind of hard to get, right?
It is. I mean, well, it is, but we're hoping to make that more accessible, because it is an important certification to have, and it's important knowledge to have, especially if you're going to be exposed to babies. It's really important to know the basics, and a lot of times you're not going to be able to get that without a program like NRP. So, but yeah, the program itself hasn't truly changed that much. There's some fine-tuned tweaks that have been made over the years with stuff that they know that has changed, or that they know that works a little bit better for these kids, but the basics are still the same of it. It is very simple. You just control the airway. You just control the respirations for them, and as long as you can do that, the babies will be fine.
So when we talk about these babies that are born at home or born outside of a level 4 NICU or what have you, a lot of people, honestly, straight up honest, in paramedic school, we talked about APGARs. We had a quiz on APGARs, and then I never saw them again until I went and took the FPC. How important are APGARs for y'all, especially in downstream care? Do they matter?
Yeah, yes and no, I guess. It just kind of depends on your situation, I would say, because they're subjective. What you see and what I see might be different. I've been working with these babies for 11, almost 12 years, so I might give a 8, you might be like, oh, that's a 6. So yes and no. It's important when you talk about things like a truly devastated baby who might need cooling therapy or something like that. That kind of plays in. But if you don't get them 100% right, there's so many more things that can take you down that route.
The biggest thing is recognizing sick or not sick, right?
Yeah,
so
right.
If you have a devastated, I like that word. Y'all use devastated a lot. If it's a truly devastated baby or stunned baby, that's a problem versus a baby that's relatively fine or normal.
Yeah. And with the APGARs, what it can do is it can help once you get good practice with it. Like Lauren's saying, if you've done it for a lot of years, her and I are probably going to assign the same APGARs. So yeah, it does help, because then when someone like Lauren is assigning APGARs, and she says, well, the APGARs were 10111 or whatever, however you may get there, that's going to really matter when it comes to taking care of that baby in the NICU or further down. But now if you have someone who hasn't had the chance to be able to assign APGARs, or if they're still learning, so well, APGARs were 8 and 9, but we did chest compressions for 5 minutes, then to me, there's a disconnect. So, but the hope for us, and the hope with what some of the education that we've been able to do, is to kind of fix that disconnect and kind of get people all on the same page. Because like she said, it does matter, but then in the grand scheme of things, does it? Yes, no, but our hope is that they can kind of get all like us and be able to be confident with it and comfortable with it, and that really just does come with more education and more repetition with it.
Some of the things I think about with APGARs is it's a in-the-moment way to remember how to assess a neonate. Mm-hmm. It's an in-the-moment way of, hey, I haven't touched a neonate in a couple of years. I've been working on the truck, and I Now I have the spontaneous delivery at home. All right, let me go off and check this box and say, all right, these things are the important things as far as looking at a baby and make sure they're not stunned or they don't need that resuscitation. They don't need some kind of, whether it's, CPAP or respirations or whatever, recognizing sick or not sick. It's here to help you as a guide.
Mm-hmm. Yeah, that's accurate. It is, because if someone, you never have as many people as you really want in a big bad situation with anybody. I think, like, when you have an adult that's down and devastated, or you have a kid or a baby, you never have enough hands. But in the perfect world, when you have enough hands, if you do have someone who's available at that time who's not able to be hands-on with a baby, that's a great thing to assign them to do, because it can help. It's almost like having someone running the code, and that's as important. Like, okay, a minute's been up since you gave your last dose of epi or whatever. So that would be the ideal situation. It's not realistic because there's never enough people in those situations. But yeah, it is a good way to be able to help guide you and
use that person as like a 10,000 foot view to kind of just say, all right, this is what overall picture, this is what's going on, this is where we're at, this is where we're working towards.
Mm-hmm.
Some little tricks I just wanted to ask y'all. When you think of the top of your head, how do you know when a baby's not okay? Like, when you walk up to a baby and that's in an outside hospital, or you meet them somewhere in the truck or wherever you guys are, how do you go, oh, this is sick? What's some things that just immediately pick off in the top of your head?
I'd say with our babies, the number one thing is respiratory. So that's the first thing you're going to notice. You walk in and you hear them grunting, we need something. And a lot of people, mistake grunting for, oh, they're crying, that's so cute. It's not. It is SOS.
Yeah, not cute.
not cute. So a baby, when I walk in, that's got, pretty good retractions, is grunting, that baby's not well. That baby needs something. Anything else?
Well, because for us, color's going to change later.
Yeah.
Like, so it really does truly, babies present respiratory a lot of times quicker than anything else. You're not going to lose, if you're looking for it and if you're just like hands on the baby all the time, but really you're not going to be like, oh, the pulses are diminished, but everything else is okay. Or you're not going to say, oh, his activity is a little off and then he falls apart respiratory wise. That's usually not the case. Usually you'll have an active little baby who's kicking and screaming but pulling to their backbone when they're breathing. So yeah, respiratory for us is really how we can tell. And then sometimes it's instinct.
Yeah.
You may look at a baby and they're actually like everybody else in the room, they're like, oh, he's fine. He's fine. We have him on CPAP, but people feel like he's fine, but it's just,
I swear it's something about their eyes.
I know,
you
I
look at them
agree.
like, oh, you don't feel good.
Because they can't tell us.
Yeah.
And their vital signs are always so subtle when they change. It's never.
Mm-hmm. They're good until they're not.
Yeah.
Like, they will compensate until they can't.
Mm-hmm. And when they can't, it is done for. Because you don't lose blood pressure. That's later down the line
right,
too. Like
late.
Mm-hmm. So it is kind of instinct. It's kind of experience, and then it's also just respiratory.
So another thing I think of when I talk about these babies, y'all mentioned respiratory. The sucking to the backbone is like that big thing. The other thing I notice is like the shallow breathing. The ones that are just like kind of, guppy's not the right word, but they're just shallow. They're right. Oh, well, the rate's right. They're breathing 40, 50 times a minute. Oh, the rate's totally normal, right? That's where it should be. But they're not even, like, they're barely moving their chest, and you can tell they're not really moving a whole lot of air and not a whole lot of gas exchange going on. Do y'all sit there and look at the chest rise and fall? Is that something that truly is a big deal as far as assessment?
Oh, yeah.
That's one of the first things we do before we ever, touch them, try to listen or anything like that, is just look at them, look at how they're breathing, their color, like all those things. Just give them a minute before you ever start manipulating them, because you start messing with them, they're going to start getting active. So that's really the very first thing we do, is just get a good look before we ever touch them or do anything.
That's another important thing to talk about. You look at them before you start playing with them. Now, obviously, if you catch a baby at home, it's a little bit different. You're probably going to be holding them or giving them right to mom. But if you walk into an outside hospital and you're assessing this kid, take a second and look at them before you start messing with them. The second you put that stethoscope on the baby, what are they going to do? They're immediately, it's stethoscope is cold.
It's cold.
Doesn't matter if you kept it in isolate. It's going to be cold.
Yeah.
It's colder than what they are.
Yeah.
So they're immediately going to shun you. A lot of times they do that whole, like, it looks almost like posturing, but like they just suck in everything and they're like, oh, it's a tingly.
I hate that. Get that off of me. Yeah.
And so you make sure you look at the kid before you do that and figure out where they are, because like you said, Lauren, as soon as you stimulate them, they're going to try to rebound and reback, and they're going to increase their respiratory rate, increase their heart rate. Everything's, oh, okay, everything looks normal. And then you stop messing with them, let them chill, and they're just going to watch their slowly bounce. As far as guessing a weight, Now, y'all are awesome. You have scales most of the time. Most of the time, before we get somewhere, when I'm working with y'all, we know what the weight is or somebody's measured them. Is there an easy way for y'all to kind of like say, all right, everything's weight based? Everything pediatrics, whether it's neonates or above, there's all weight based. Is there ways y'all use to kind of guess the weight?
I mean, yes and no. It's experience again, I think, with that. Anytime that I feel like sometimes we get it right on the nose, and I'm like, oh, this baby's 583 grams, and up pops on the scale 584, and it's like, oh, I'm close. And then other times it's that same baby, and I'm like, oh yeah, he's 900 grams, and I'm way off. So like, it's not really necessarily like a great way to. Like, I don't think you can really truly look and like hit it on the nail,
Right.
with the nail on the head. But I think
Yeah.
if you can kind of at least know about what mom's gestation was, or
Yeah, you can get pretty close.
You can get
to
close.
the weight if you know the gestation. You know.
and it may vary like by 100 to 200 grams, which is big on the
But yeah,
smaller ones.
a
But
big jump in your 23 to 26 weekers if you're off by 100 or 200
oh, that's
grams.
big.
That's gonna be
a lot.
That's gonna
when
be
you
a
start talking
lot
about
when
volume.
you start talking about volume and meds and stuff. So.
But mainly, if you can kind of just familiarize yourself with what the normal weights are, or like close to what the normal weights are for an estimated gestation, then you'll be on the nose. Like, we know a 23 weeker is going to be about 500 grams. So if we're going to a delivery that doesn't have a place where they don't have scales or anything like that, we'll estimate kind of just based off of what we know each gestation is. There's some great resources there on the internet too that kind of have good like tools of saying how much does 800 or how much does a 28 weeker typically weigh. You can Google that, really. I mean, if someone's saying, hey, I'm
Yeah,
going
if you're
for
in
6 months,
Yeah, you're in a bind and you're like, oh man,
hit the Google
yeah,
machine.
hit the Google.
I'll put some of those links in the show notes, guys, for y'all. But they're honestly, that's what I use. There's a link. I can't remember it off the top of my head, but it literally says 26 weeks, 28 weeks, 30 weeks, 32 weeks. It doesn't do every week. It's just every other, and it does pretty good.
Yeah, we use one for Stork too. That one that we've made that kind of just is like clear and concise, and that's based off of the 50th percentile for each baby. So I mean, it may get you close. It'll get you close.
It'll vary some, but you'll be pretty close.
But in a bind, unless you're really comfortable with babies and knowing that, like, oh yeah, a 29 weeker, that's about like 1,100 grams ish. Just look it up. That's what I mean. I'm not gonna lie. When we're tired or we're just really not, I hit that
Just
Google
get along.
machine.
Yeah.
So when we talk about we've guessed the weight on this baby, we figured out this baby it's at an outside hospital. We realized, hey, they're sucking all the way, they're grunting, they're sucking all the way back to their chest. Respiratory management on these kids. Talk about a little bit about NRP, but basic airway management. A lot of people, especially when you talk pre-hospital folks or even outside hospital, they want to jump right to intubation. And
or not.
Let's talk a little bit about just basic airway management, some of the stuff you do, especially when a kid just pops out. You can just give them bagging for a few minutes and they do fine.
Pressure. I mean, babies need pressure. So a baby who's in respiratory distress is not going to do well with just blow by or a little bit of nasal cannula. They need CPAP. They need that PEEP to help open up those alveoli. So I think that's the main thing. But you have to use it in moderation too, because you have to think these babies are freshly born. I can't just throw CPAP immediately on them, because then you're at risk of popping a pneumo, which happens a ton, especially with the bigger kids. You would think it would be the smaller ones when you use CPAP, but no, those big babies. The second you pop some CPAP on there, and if you don't have it just quite right on them, you will pop a pneumo. But anybody who's grunting or retracting, that's going to be pressure always and forever. CPAP always and forever. I know that in some deliveries that we will go to, you'll get that 36-ish weeker who is just grunting and retracting. You can hold CPAP on that kid for about 20 minutes, and usually that's all he needs or he or she needs. So if you just give them time to transition and let them kind of figure it out and support them through that, you don't have to get to the point of intubation. It really is less is more. So in that situation, if you just sit there, hold face mask CPAP on these kids, freshly delivered, they'll usually turn around. When you would transition to intubating those kids would be, after like if you're sitting there for 30 minutes and they're just still grunting and tachypnic and you have really given them good chance with that CPAP, that's when we would maybe admit them to the NICU then and get an x-ray, see what you're looking with, and then they may or may not need some Curasurf and intubation. But even then, that's not a lifetime of being on the ventilator. A lot of times you just intubate, give the surfactant, and take out the tube, and the babies are usually fine. So every baby's different, so it's hard to say like, okay, a 36-weeker, X, Y, and Z, here's what you're gonna do, because that same baby, that same case, but in a different baby, may need to be intubated right away because what you're doing is not going to work. So the main thing, if you can remember, with kids who are in respiratory distress is pressure. PEEPA 5 to 6, but start with 5, less is more. And then just give them a chance. They don't all need intubated. Anybody in respiratory distress does not need intubated. Small babies do, though. Like a 23-weeker is going to require intubation.
It's hard to hold a face seal anyway on that. I mean, when you start talking about something that's 500 grams, I mean, it's an art. I mean, sitting there watching them all do it.
Especially when you're out in like these rural hospitals who don't have nurseries or don't have whatever, they're working with limited equipment. So, you know, it really is hard for them to do that. So.
Not even do you have the right size mask, but like, do you have the staff that can do that? Do you only have 2 people in there and you got one that's holding CPAP and one's running around like a chicken with their head cut off kind of thing, trying to do everything else they possibly can?
But what's something that's changed is that they are trying to get away from intubating in the delivery room. Like the babies that it used to be 5 or 6 years ago, for sure, a 26-weeker was getting intubated in the delivery room. 26, 27, 28 weeks, you're getting intubated. Now it's transitioning. Sometimes some of these babies do not need intubated, and bubble CPAP. Those babies get bubble CPAP, and they'll sit there on bubble CPAP. They'll go down to the NICU, get in and out, cure surfed, and then transition right back to CPAP, and those babies do great. So like that part's evolving, which I think is great because these babies do so much better. But not everybody needs to be intubated. No, little guys do. Again, yes, I stand by that. The 23-weeker needs to be intubated. Yep. But if you can intubate, CPAP or do PPV with the face mask.
If you do, end up needing intubating, don't, I guess, continue to do it when you've failed, because you're just making that airway that much worse too. I mean, you're making it that much harder for the next person and that much harder on that baby because you're going to cause all that swelling and stuff. So if you do get to that point of intubation and it's just that tube's not going, you can always bag a baby. You can always continue to hold that CPAP or just face mask bag a baby until, someone else can get there who has a little more experience.
Yeah. These are one of those cases for me. It's set yourself up for success the first time. Make sure you have all your ducks in a row. There have been very few cases, and all the time I've get to work with y'all, that we've rushed to intubate a baby.
Right.
Maybe like a handful.
Right.
And those were, it was something respiratory that they needed it, some weird case or something like that.
Yeah, for us, if you just take your time with it. I mean, I think that's true for any, I guess, intubation with anybody. But I know it might be different. Babies with adults, we can sit there and do PPV forever. And so if Lauren and I are going on a call and we get there and we're like, okay, this baby needs intubated, one of us takes over with the airway and just sits there and lets them remain on whatever they were on, or maybe give them a little bit more support with the CPAP or whatever. And then you just take your time gathering your stuff.
Yep,
take
get
your
everything
time.
you need. You don't have suction at the bedside. Wait just a minute. Let's get something. Because like you said, you want to set yourself up for success for that first attempt. Like so take your time. Get everything that you're going to need so that you can.
That neonatal airway is tough. And it's not just because I talked about this before, but it's not because like we just think, oh, everything we do is hard and da-da-da-da. It's not that. It really is. That one study I think I've talked about before, it was with 10 academic centers. So it's neonatal centers that's all they do. The delivery service, that is what they do with neonatologists and the neonatal fellows and neonatal nurse practitioners, the people who only do babies at these deliveries. And they were measuring what the first pass intubation rate was in the delivery room, and it's like 45%. And that's typical, and it's because these airways are difficult and all that. So you're only going to set yourself up for failure if you don't take your time and prepare yourself. And that's not the reason why they're missing it. That's just because these airways are difficult. So you don't want to have an attempt because you weren't prepared also.
Real quick on tube sizes and ET tubes y'all use. I know you get mad at me when I bring out a cuff tube anywhere.
No, cuffed tubes.
No, cuffed tubes.
Even when I'm talking about pediatrics, you're like, what is that? I don't want it.
No, please no.
Which can be a challenge for us. So like we're using the Hamilton T1s now. They're a pressure-driven vent. You may require a little bit of additional pressure to get you the patient-delivered pressure you want. And the vent T1s will compensate for that. But if you're using something that won't, that's something to consider as well. These babies, trying to use cuff tubes in them, you're going to cause a whole lot of problems
Yeah.
downstream that you don't need.
Mhm.
As far as ET tube sizes, the two as low as I've ever seen
Yeah.
anybody carry.
Yeah.
Those are typically fine for the 500 grammers, and it's not an
No.
issue.
Well,
Yeah, even then, I mean, you want a 2.5.
2.0 tubes are so hard to manage.
They are.
Um,
You can't suction them. There's no, catheters that'll go down that far. It's hard to give CuraSurf through them. They clog up. It's just, they're impossible to manage. I mean, yeah, you can get it in and you can give them ventilation through it, but that's it. Like, they're going to be so hard to manage.
Mm-hmm. The likelihood of having them, like she said, plug off or having to be reintubated, and the trauma that is associated with intubation for those smaller babies is insanity. But the cuff tubes, the reasoning with that is less is more. Also, so we can deal with a little bit of an air leak because these babies
Right.
are so little bitty that if you put a 3.0 in a kid and you inflate it, when really it just needed a 3.5 maybe, and if you overinflate it, you're going to cause so much damage on these kids.
Plus, a whole lot more likely to get a pneumo. If you block it off where there's not an air leak, there's nowhere for that air to go.
Ugh, I hadn't even thought about that. I mean, I haven't.
I mean, it's more
Yeah.
pressure, right? It's a closed encapsulated
Yeah.
space versus
Yeah. So we
you have a
we
little,
will
you have a little
tolerate
wiggle room.
we tolerate having air leaks as long as the baby's oxygenating and ventilating as opposed to upsizing. Now, if a baby is decompensating or if you're not ventilating or oxygenating, we would still upsize the tube versus putting in a cuff tube just because, again, if I put a 3.5 in and I'm like, oh, I got an air leak, let me fill up this cuff a little bit more. The damage that you do with that. And then those babies end up with trachs. And in the meantime, okay, yeah, I've got a great gas and I'm ventilating my baby, so in the moment I'm
yeah,
happy.
it looks
But
so good right then.
yeah, but the long-term damage that you can
it's so
cause
hard
with
to
that.
extubate those kids.
And it's hard to extubate a kid who's got a proper size tube, and a lot of times they have real bad stridor afterwards. They require steroids, they require racemic epi, when that's just because the physical tube's just in there. So I can't imagine putting in a cuffed and then
Yeah.
No cuff tubes.
Real fast on tube sizes. What are the tube sizes associated with weights for y'all? Just so because y'all can spit it off the top of your head like it's nothing. No pressure.
It's not that. It's the fact that, like, yeah, you'll get a 1,500 gram baby, but you go look and it's like, oh, I can actually fit a 3.0, or I can
3 in here.
or you go to look and it's like, that's a 2.5. So it's
they do have like a weight. It's like less than 1,000 grams.
a
It's
2.5.
a 2.5. 1 to 2 is a 3.
3 to
2 to
me. Gonna make me have to Google.
2 to 3 is a 3.5, and above 3 is a 4, something like that.
Yeah.
But yeah, you don't ever know. I mean, you can guesstimate. I think I can, for this size baby, this should be this tube, and you get in there and you go, well, that's a narrow airway, or I can get something bigger in there. It just kind of, depends. You don't ever want to get in there and have to shove, like,
Never shove.
Don't corkscrew it.
never corkscrew a tube in somebody, please.
No.
I feel like that should be for anyone.
No,
Just
golly. Let me
The,
go. If you're screwing that in me, let me out. I'm out.
Just let me go.
It is my time to leave here.
The biggest thing I want to take away from what y'all just said is you get in there, you look, it's just like anything else. You should have a tube size above or below.
Above and below. Yeah.
And in these kids, I would even argue you may want to just have all of them. Go from, I mean, now if you're going for a 500 grammer, you're not going to have a 4 out. Let's just be honest.
Yes.
Right.
But
Yeah.
if you're getting that, that 3 grammer that hey, you look in there and somebody's gone a couple times before you and intubated a couple times, like, hey, I'm not fitting a 3.5
Right.
in here. I may have to fit a 2.5 in
Yeah,
here.
you have
Right,
to take that
or-
into
yeah.
consideration too. If you've been someone's tried to intubate this baby 6 times already, there's gonna be some swelling around in there, so you're gonna may have to have a smaller size too.
Yeah, we'll have both of them available. I know that we've done that because you look and you're like, ugh,
Mm-hmm.
that ain't going.
Yep.
And again, less is more. You don't want the perfect seal, the perfect fit. I'd rather have something that kind of. I mean, I don't want an air leak, but I don't want it
Yeah,
to
but
be
that's not the end of the world.
No,
You
I don't
can-
want
you
a
can-
snug fit.
Yeah,
either.
as long as you are getting the pressures the kid needs on the ventilator and they're oxygenating fine and they're not in any, distress afterwards, you're golden.
The other thing with LMAs or supraglottic airways and all that kind of stuff, they're very rarely used in neonates.
Mm-mm.
I mean, I know they talk about it in NRP, they talk about it in a couple other different courses and different literature, but I would venture to say I have never seen one floated.
I've
here.
never put one in.
Yeah,
I mean,
Um,
either.
with any of our team members, we'll just bag them. It's a lot safer to bag them. It's a lot easier, and mainly because you throw that thing in there, it's trauma on the airway, it's trauma on everything in the back, posterior lower pharynx. Everything gets swollen and pushed and moved, and
all that air. I mean, I know that's not the goal, but all that air is going into the stomach also, so you're eventually going to just be causing yourself trouble.
Yeah, causing them more respiratory distress. You got that abdomen pushing up on their, up into your diaphragm. That's just going to cause more respiratory distress for them. So,
but we do have it.
We do.
For those very occasional. I mean, I feel like we're going to jinx ourselves, and now we're fixing to go
when
for
you talk about something you never do, and here it comes.
But then, I mean, with facial anomalies, though, like a Pierre Robin or anything, a bad cleft palate and lip that is in respiratory distress that you can't get intubated, of course we'll do it, and we do have it. It's just
rare. It's rare to be that we use it.
Now we've summoned it.
We have. We've done it now.
Real fast with NRP and the 8th edition updates. The only reason I wanted to bring this up is there's a couple of them that are big. Would y'all like to speak to those real fast? Mainly the epi is my main big thing.
Yeah. So with the epi, before it was like a range, you kind of do like a 0.01 to 0.03. Now they say just go straight for the middle, so it's 0.02, which is 0.2 mils per kilo.
Makes the math so much trickier.
It really does.
Like, it really does make the math so much trickier in an emergency.
But yeah, that's really the only thing with the epi. It's just that kind of middle ground. Instead, you always have that 0.1 to 0.3. You can go up, but now they just straight start in the middle. 0.02 milligrams. It's 0.2 mils per kilo.
Yeah. The other thing that changed is it used to be that chest compressions would come before the airway or intubating. But they've switched that. So now they want you to be intubated before you proceed to chest compressions. Now, if you're in a place where you weren't prepared for this and you don't have your intubations,
yeah, by all means, don't
do your chest compressions, right?
Chest compressions,
do them. But if you're in the perfect situation where you have everything ready, the idea is that if you get to that point of requiring chest compressions, they would like for an airway first, because they know that the babies are respiratory driven. If you can control the respirations, you're not going to get to that point.
You don't have to get to the point of chest compression.
Yeah, so that was a major one that changed.
Such a small percentage of babies actually need that full resuscitation like that, the chest compressions and the epi. So yeah, that's behind that. It's just getting that airway in, and you can turn them around hopefully before you ever have to do that.
But it's hard just to sit there and watch, though. It is so hard.
It is, because it feels like forever. It's really not, but it just feels like so long, and like you're not doing anything, but it's really best.
It's almost like time slows down. You go in that Matrix moment.
Yeah,
absolutely.
100%. 100%. And because I'm telling you, a minute of bagging after you've intubated and that heart rate's still just, I mean, it's climbing. It's going to climb.
Yeah.
But if you started off with a heart rate of 30 and you see it just slowly improving and climbing, it is so hard not to still jump on chest compressions while you're watching that improvement happen. It is so hard. But again, if you're not in the perfect situation and you have to grab your stuff, do your chest compressions. That's not gonna.
Don't ever withhold it just because you wasn't prepared.
How does that phrase go? 1 and 2 and.
Oh Lord, help me. The ADD in me has to say it.
1 and 2 and 3 and breathe. That's your cadence for chest compressions, coordinated with bagging.
It is important to be coordinated, because if you're not coordinated, if Lauren's doing chest compressions and I'm bagging, depending on the pressure I'm using, the compression she's using is going to overpower whatever PPV I'm giving. So I'm not going to be effective with my ventilation, or vice versa. If she's kind of all over the place with her chest compressions and barely giving them, A, they're not going to be effective, and B, whatever I'm doing with bagging is going to overpower what she's doing. So being coordinated is really important. It is silly to have to say that, to say it out loud. I
still do it. I do it every time. I
mean, we just walked into a place the other day and I said, "Ugh, this is like it," but it's fair because there was chaos happening, so it's not a knock on these people. But you go in there and you kind of see the chaos, and like everyone's kind of talking to each other, and you see these chest compressions are going at 1 million beats per minute. The bagging is not happening, so you just walk in and if you just say it out loud, people are like, "Ooh, whoops, I'm not doing it," and so you just 1 and 2 and 3 and breathe, and kind of when you start doing that, people kind of just like.
Everybody relaxes.
Okay,
everybody in the room is like, okay, now we're back on the same page. It's a good way to kind of, like you said, control the chaos, bring everything back together. All right, this is what we're going to do. We're going to do 1 and 2 and 3 and breathe.
Yeah. Well, because truly, when you get to the point of a code like that, it's so rare that these babies actually get to that point. So whenever it does happen, it's natural for chaos. That's everywhere. That's at your big centers. That's at your smaller centers. That's everywhere. That's for us. If we're on a call and we get somewhere and we're expecting this healthy baby and we get there and we didn't prepare ourselves and they code on us, we're going to be chaotic. I mean, that's human nature. So it's not, that at all is not a knock on experience or
No,
anything.
I've had to do that to myself, just bagging a baby like, oh, slow up, Lauren, breathe, 2,
You've done
3,
that to me.
just,
You've done that to me.
yeah.
Yeah.
Both of y'all done it to me like, hey, all right, hey,
slow it
count it.
down, buddy.
Oh,
Count
we'll
it.
pop a hand. Yeah, we'll pop a hand real quick. Man, you're going too fast, or slow it down. Yeah, we'll pop hands real quick.
I remember me and Brad, we used to work together all the time and be like, all right, did you get hit today or no?
Yeah. Yeah, we'll pop you real quick. Ain't no shame in our game.
So when we talk about doing CPR, just real fast, because a lot of people ask, what's viable and what's not viable? It's not always everybody's favorite subject, but
It's not.
there's some of the things that have changed. Like when I first started with air care, it was 24 weeks, and there were some 23 weekers that magically made it, but it was, all right, if it's less than 24 weeks, this isn't happening.
Yeah.
What's everybody going towards now?
Well, 23 weeks is truly where they say, yes, you're viable. That's it, but it's also based off of weight. Some places it's less than 500 grams or 500 grams and below, they're going to call you non-viable. But again, it's kind of when you're on that borderline, it's very tricky. We've had 22 weekers, and we've had 22 weekers who have gone home on room air and PO feeding and fine. So that's kind of changing with the technology and the equipment that we have and just the education that we have with resuscitating these smaller babies now that's kind of evolved. So it's moving closer to 22 weeks. Those babies are really hard to manage, but I mean, I'm not going to lie. If I had a child myself and it's a 22 weeker and he or she is 400 grams and breathing and trying, I'm going to say, for me personally, try. I mean, don't do anything heroic and don't code my baby for an hour, but like if you can get that child intubated and have a pretty stable resuscitation, I think that's reasonable for that 22 week range and have it be right there on the borderline because that's what we're seeing now. Now we're seeing these babies are surviving.
If you got the 22 weeker that's in arrest, it's basically stillborn almost.
I would let it be.
Yeah, there's no need to go.
Yeah, I mean, if you come in and they're doing like nothing, they're delivered and that it's nothing, and it's 22 weeks, usually those are ones that they're just non-viable.
Yeah.
Now, if they're, 22 in a couple days and they come out and they have a respiratory effort and, parents say, I'll try.
Yeah.
You bet.
Yeah,
game on.
respect what the parents want by all
Absolutely.
means. And I mean, and that is their child. So who am I to say at that point? That is
it's
tricky. It
very
is
tough.
There's nothing that we enjoy about when we get to that stage, that pre-viable. And that's everybody. I'm not going to say that's just me and
No, that's
you
everybody I've talked to ever about it.
It is the hardest thing ever because that is somebody's baby.
Yeah.
And that is a lot of times like a very wanted baby. So it's ain't nothing easy about that.
There's nothing easy about the comfort care. There's not talking to mom and dad everything about it's challenging.
Yeah, I think the best way to handle it in the perfect situation when you have all the time in the world, which it never is, but if you ever do, have a conversation with the family beforehand if you can. What are your expectations? Here's what we know, and help them just understand kind of what their situation is, and then allow them to come to a decision with your assistance, and then just respect that. I think. I mean, it is ultimately their child, so I think it's now again a 21 weeker. Unfortunately, that's not going to be
viable.
But who knows? Maybe one day.
Technology is always changing.
You think about
we can figure out that bubble thing out of
years.
space where like they just sit there in an incubator and we grow them and show them and everything else and everything works out.
Oh yeah, I mean, because you have not. How long have you been here? Like 8 years?
7. Yeah.
Yeah, and so like in just that amount of time, it went from 24 weeks to 22, and that is tons of babies. So who knows? I mean, we don't know what's gonna happen.
Yeah.
We just need to do what we think is best, and that's tricky.
It's challenging. It's one of those, but that's why I want to bring it up. It's everybody always asks, like, well, what do you do? What do you do? How do you handle it? This, that, and the other. And there's a lot to it.
Yeah.
But if they're 20 weeks, they're 20 weeks.
Yeah.
If they're 21 weeks, they're 21 weeks. If they're 22, okay, this is where that's the gray line.
Yeah. Starts getting a little hairy there.
Yeah, I wouldn't want to be the one who's in charge of making those regulations. And thankfully, and again, I'm afraid that we are strumming this up again, but thankfully we're not put in that position very often.
No.
I mean, I know it happens, but we're not making that decision very often, thankfully, because there's It's not easy. That is not an easy place to be in.
On a little bit happier subject. So let's talk a little bit about Stable. And the reason I want to talk about Stable, for those of you who don't know, it's a course. It's wonderful. The 20 minutes after NRP, or after the 10 minutes of resuscitation, you get the baby back. You've managed the airway, put them on CPAP. A lot of people have trouble with, okay, great, I have a baby, we resuscitate them, they were born, I've done my 10-minute APGARs, everything's hunky-dory. Now what? What do we, when we start talking about Stable, I go back to it and I keep saying Stable, but honestly, it's what I use every day.
Yeah.
All right, so let's do the sugar. That's the first thing off the list. Is that something y'all use? Is that a great mnemonic? What?
We are big fans of Stable. Yeah, it is a great way to be able to kind of just like organize your thoughts after now that this baby's come. Now what? Now, especially if you're in a place where the babies don't usually stay there.
Yeah.
And
you have to ship them out somewhere. So. Yeah.
And the perfect world, they're gone right after delivery, but sometimes things happen and transport's not available or
ice storms, tornadoes,
yes,
hurricanes,
and
all
that
those
baby's
things.
going to be staying with you
for
overnight.
Like 8 hours. So
yes.
What do I do now?
Yeah. Again, babies are simple. It really is simple. Stable. It's a mnemonic. So the S in Stable is sugar. So as long as you're checking, I'm going to err on the side of if you're born in a place that typically does not birth children, be that an ER or a car or a house or the side of the road, I'm going to say that's a place that a baby's not typically born. So just treat them as if they are hypoglycemic. I'm not saying do all the things, but check a sugar. Yeah. I think definitely at least in the first like 30 minutes. Now, you don't have to check a sugar right after your 5-minute APGAR.
Right.
Let's sign, give that baby.
But just give them a heel stick, see what it is. All right, cool. Am I above 30? Am I not? Where do I sit?
Yeah, and hypoglycemia for neonates is weird. They don't have like a definite number. Some people will say 40, perfect. Oh, that's too low. So it's hairy. Usually like anywhere from, I don't know what Stable's saying now, 40 to
I think they're going with 45.
45.
But they say the same thing that there's no great literature because what is a baby's normal glucose supposed to be? Because every baby responds differently.
Yeah. And I mean, you say, okay, 40 to 50 or whatever, 45. One baby's glucose of 45 may not be the same as another one. So I've seen a baby with glucose of 40 and they're jittery and you're like, oh, this baby's hypoglycemic. I've seen another baby with a glucose of 2 looking at me like, what up?
Yeah.
So like it's hard.
Yeah.
I think we say that a lot. Every baby's different. Like you just
30 has always been my number because I know if 30, it's got to be a little bit low for somebody.
Yeah.
It's not enough for their brain to perfuse all the way in my mind. And it's also half of the adult 60. So I think of it, all right, they're not half the size, but they're little things. So 30 or up, great.
I would go with even 45 to be honest. I think, well, especially because if you're in a place that doesn't have the things, err on the side of a little bit higher.
Yeah, because if you get it and it's like 35 and you're like, oh, well, okay, so you're not up in trying to do anything about it. You check it again later, and then it's 10.
Yeah, that's not good.
So at least 45 kind of gives you some room, too, if it's a baby that can, in Stable works, I'll say Stable works with stable babies also. You still have to check those sugars and do those things because your term baby who just delivered in an ER, fine otherwise, they could have hypoglycemia, too. So, like, Stable's not just for the sick ones. That's a pretty good like basic
they have a higher metabolic rate. They're going to burn through sugar real quick. They don't have all the fat, so make sure you check it. How often are y'all checking on this? It's totally stable baby, everything's hunky-dory, term kid, whatever.
The perfect kid in the perfect world with
first one's in 30 minutes, the second one after an hour, after 2 hours even?
I mean, honestly, we don't check them that often. A normal stable baby who mom wasn't a diabetic or mom doesn't have any of these risk factors that you would want to be looking for a hypoglycemia issue in the baby. Typically those babies, we might get a admission glucose on them, but unless they are doing something weird, just feed them. If mom wants to breastfeed, let them put the baby to breast whenever she wants to, feed them every 3 hours or when they wake up for a bottle. And I mean, unless they're giving you some kind of clue that something's wrong here, we don't generally check them on the term well babies.
No, if the mom, so some of the risk factors for mom, of course, are diabetes, but also hypertension. If a mom's on a beta blocker, that'll be a reason to follow. So beta blockers, and then if the babies are growth restricted.
Yeah.
Also, so that's what we're coming into knowing, just like the normal weights and sizes of babies when they're born. So growth restricted babies are higher risk of hypoglycemia. But like she said, you can have 0 risk factors and check your first sugar and it's 2. So I would check everybody.
Yeah.
But once, as long as it's normal.
Yeah, it's normal, and it's a baby that you can feed or that you can get fluids started on. Like if it's one of the smaller ones, this baby can't take a bottle. Start some fluids.
Yeah.
As far as just that kind of leads into glucose management. So for these kids, typically we're given D10.
Yeah.
We'll put some show notes on the wonderful thing that Emily made about how to mix glucose. But
that's a sensitive subject, man.
But D10, dosing for D10, 2 per kilo.
Yep.
That's unchanged.
Mm-hmm.
If you need to give it, by all means give it.
Mm-hmm.
The other thing is maintenance. So you talk about fluids. So what are y'all's things on, or what are y'all's, I don't want to say protocols, but what are y'all's fluid management
like
now?
Maintenance.
Yeah, maintenance now.
For your, term babies who are hypoglycemic, whatever, it's usually around 80 per kilo. For your smaller babies, you're going to kind of go up on that fluid, 100 to 120 mils per kilo per day.
Mils per
Say
kilo.
that again. Mils per kilo per day.
And it's either, most of the times D10 or D5, one of the two.
So yeah, the littler babies are tricky because they'll become super hyperglycemic. So we'll start them on D7.5. So anyone who's 28 weeks and below, you can get away with D7.5 at 100 per kilo per day. And then also for the boluses, that 2 mil per kilo, that's just an IV push at the site, but do not just give that bolus and not
follow up.
Yeah, maintenance.
Yeah, you've got to give that and give something, some maintenance with it.
You got to keep them there. Once you get them up to where you want them, you got to keep them
you don't
there.
want
they will
you're just
rebound
gonna keep
hard.
rebounding.
Yep.
Yeah.
You play the up and down game all day long.
Yeah, but and then after you do that, check a sugar. Some people wait an hour. Some people wait 30 minutes. Let's just say happy medium of 45 minutes if you must.
Just recheck it.
But definitely check it. Don't just
Definitely
do
recheck
that and hope everything's better, because a lot of times you'll get these super hypoglycemic babies who are very resistant, and they'll just sit there at 20 regardless of what you're doing to them. They will not budge. So don't just think, oh, I've checked it, I've treated it, I'm done here. Follow up.
There's been a couple of those kids that you bring them back home. We go down there and fly down there. Oh, they're on D10 at 120 per day, and we're like, all right. By the time they're back here, they're on D15.
Lauren just had one that's on D25.
I mean, they're which
Lucas at 2.
Yeah, that would not budge, and the IV was in.
Yes, we had multiple IVs actually.
Working back to stable. So S is for sugar. Pretty simple. T is probably
temperature. That's my favorite one.
Temperature.
I would say
Emily shines.
I won't say it's the most important, but it's right there.
It's
it is
so the
important.
most important.
Yes,
I'm going to
so
tell you,
important.
I have changed the way I practice. The T is temperature. It is in my ABCs. I go ABC T.
Yes.
I want temperature up there as important as airway.
Yes, because you can do all that stuff, and if you have a cold baby,
they're gonna die. For lack of a better word, there's no pretty way to say it. There's no sugarcoating it. There's no, oh, it's okay. His temperature's 90. No, it's not. And especially on the smaller babies, it's just, but it is because it is just not harped on. And I think if we kind of change the culture as making it as important as the airway and all that, then you can really improve the outcomes of these babies. You can run a perfect code on a 23-week or a perfect code. Everything goes beautifully. And then you go to check a temperature, it's 89, that baby goes to rewarm, and they will decompensate and a lot of times die because of that. Yeah. And I feel like temperature is something so easy to control.
So easily.
Yes, I know that I can pop you on a warmer. I know I can use a mattress. I know that I can put a hat on you. I know I can wrap plastic on you. I think as long as you put that in the forefront of your brain, you're going to improve your outcomes of these kids. It's just something we don't think about because it seems so silly.
Right.
Like, oh, a little hat for this baby.
In the grand scheme of things, temperature, but it matters.
It can make a huge difference. I can't tell you how many kids, not necessarily neonates, but especially the older kids, and we'll fly down there and they are, we get this picture of their sick as snot and this, that, and the other. They walk in the door and their temp's 91. Literally stick them in the pizza box, put them in the isolette, put them on a mattress for a minute, warm them up, and they're all, hey, what's up? I'm here. How
Well,
you
that's
doing?
the ideal. Usually it's, hey, I'm dead now.
Yeah. Yep, you warm them up and their blood pressure
Yeah, they
tanks.
vasodilate.
Yeah, I mean, they just,
They don't
they hate
compensate.
life at that point.
Yeah, they don't compensate effectively because they're
Yeah.
new babies into this world, and then they get cold and they're trying to regulate, and rewarming those kids is difficult.
So it's not something we just rush into. You don't just
No.
throw them in the oven and say
No.
cook them.
No, God
It's
no.
like a slow raising of their
Yeah.
temperature. I mean, we've gone on transports where we're on the, ground for 3 hours or so, and, you might start getting a reasonable temperature at about the, 2 hour,
Yeah.
hour and a half mark.
And reasonable would be like 94.
Yes, because like you said, you warm these babies up and they vasodilate and they will turn on you.
Mm-hmm.
Any baby to me that's cold, y'all know I'm a pharmacology guy. Any baby that's cold to me, I've already thought out. I may not have mixed it, but I've mixed the epi infusion in my head. It's the only drug that's going to work. Every once in a while, dopamine, you can go to that. But if they're truly cold, I'm like hypothermic, like 88, 89, whatever, because dopamine's not going to work that cold. You're in your head, all right, well, if I'm going to warm them up and they start looking a little bit better and then they compensate and vasodilate, what in the back of my head am I going to use to counteract that? And fluids are usually the first choice. Everybody gives a bolus, right?
Yeah, that'll kill.
But the part of that, well, that's what I wanted to bring up.
No sugar coating it.
The part of that I want to bring up is like people give a bolus, but they give a bolus. Where'd the fluids come from? They come out of the warmer?
Well, even that. I mean,
mean-
so those boluses, while they are cold like that, if you bolus them too fast, you're dealing with a baby who's vasodilating at that point. Hopefully it's slowly, but at that point they're vasodilating. Small babies have very friable blood vessels, very, very friable. Even if you're not giving a bolus, sometimes turning their heads too quickly can cause them to have a head bleed just with that change in pressure from the carotid. So if you give a bolus on a baby who is already very fragile because they're already cold and vasodilating and their blood pressure is very labile, and then you go ahead and switch the volume in that baby's body really quickly, they will bleed. They will 100% bleed. And what will happen is, oh yeah, well, I got a great blood pressure for a minute.
But at what cost?
Right.
Yeah, what happened downstream?
Yeah. It's not worth it. And so for us, when we hit this all the time because we do start warming and they do start getting warm with us, and then their blood pressure start to become soft. What we'll do is we'll still give that bolus over 30 minutes, sometimes an hour.
Yeah, slow, just slow. If you have warm fluids, it's a great option, I feel
Yeah.
like. But yeah, slow is the key to all of, most of it.
But not microwave. Don't put.
Oh, no.
No. But then if you're still at that point where you need some pressure, so actually for us we will use dopamine. But a lot of times, well, I don't feel like we have the baby long enough. Do you know what I mean? Like
Yeah.
I feel like we give it enough time with the bolus that by the time we get to the point, okay, the bolus didn't work, because you gotta let it work. Like, and
Oh
again,
yeah,
that's
you gotta
Yeah, 'cause
actually
you don't
let it
ever
get
know
on
what
board.
works.
Yeah.
Yeah.
You start piling all these things on
No.
top. It's
Yeah.
like, oh, well, what worked? And now
Yeah.
you're on 20 of dopamine. You're like,
so now what? Another bolus or not? Like, was it that or is it the dopamine
Yeah, you have to give these things time to
to work?
with them.
I would even say after a bolus has gone in, I would still wait 20 minutes still to see if your blood pressure is going to be better. And like typically, I mean, you should be
And
close to getting
honestly,
home.
Yeah, and honestly, if your heart rate, they don't have this huge decrease in their heart rate or, perfusion changes, I might let that slide,
Mhm.
that labile blood pressure. I'm like, okay, I need to give you some time.
Yeah.
So,
Because you just switching their.
Well, and they're getting a bolus on top of maintenance at this point. They've
Yeah.
already, I mean, so you're thinking about all the fluid they're getting. They're
Yeah.
getting, 100 per kilo per day
Mhm.
of D5 or D10. But we're talking about small babies, probably, I don't know, whatever.
D7 and a half.
do
7.5, just because it's fun.
Yep.
And then they're
like to
getting this
make our
bolus over,
work harder.
yeah, over 30 minutes to an hour. Okay, cool. Like I said, in the back of my head, I've already, Epi's my go-to. That's just
Yeah.
full disclosure.
Well-
But that's me.
Yeah.
It's in the back of my head, but what it does is it prompts me to think, okay, I need to stay on top of this. I have to, because it's, when I mix it or I'm doing it for neonates, it's on a piece of tape on my leg, and I paint it, so it's sitting there. All right, well, I'll look it around. All right, what next? And I'll look down at my leg, and I'm like, all right, well, I guess I have to pay attention to this.
Yeah. Yeah. Our dopamine's changing. I will say the use of dopamine is changing. It's still going to be the first for us. We're kind of switching a little bit more towards norepi now, which, I think we talked about
That
this,
makes
like,
me happy.
I know
I'm
it does.
not.
I know it does.
Y'all
I know it
have-
does. Yeah, because y'all have been asking us about that. I think that's the question that we get probably from adults and peds more often than not. Why
Yes.
do you guys
Why
not
do
use
you not
Norepi?
use
Why don't you da-da-da-da-da? And it is just because it is,
It's that Levophed. It's the old literature that said the Levophed was a bad drug and nobody wants to go with it, and it takes time to change. You have to prove it.
Yes,
And-
and it's so hard to find research
Yeah.
on, like, you'll find that, like, with anything with babies, it is so hard to find research on, because who's going to
Who's
play
gonna stick?
around
Try
with
it.
the baby?
Well,
what I mean?
who's
Like,
gonna stick their neck out and say, "Hey, yeah, okay, sure,
yeah,
on my
let's
kid,
try
whatever."
this. And
When you
what
know
if it doesn't
dopamine-
go, yeah.
has worked.
Yeah.
I mean, not without its risk, but it's worked for so many years. But now, Norepi's making a
Yep,
appearance.
making a comeback.
But as far as using that, I'm not going to make a recommendation on that part because I'm not going to lie to you. I don't know. I don't know. So for right now, what we would do until told otherwise is low dose epi.
Mhm.
No.
No.
Low dose
No,
dopamine,
no,
dopamine.
God, Will, you're
Disregard.
you are osmosising me. You're making me change.
I want to change you to epi, but it won't. No, it's low dose dopamine for neonates.
Yeah.
Again, epi is the back of my head simply because it's me and it makes me think code and makes me think pressure.
Yeah, but yeah, for
Um,
us it is
But it's low dose dopamine.
Oh,
For
It's
5.
usually, yeah,
5.
5.
Mhm.
Yep. But
And
yeah.
you're not going to get much change with a 2.5.
But slow
Mhm.
and steady.
Yes.
That's the race. Okay,
Yep.
so we've made it to T and stable. Temperature. Sum
Hey.
it up. Cold babies don't like it. Let them be warm.
Yes.
Control it. That
Put a
is
hat on them. You can wrap them up in saran wrap.
Yeah.
Or the fancy thing you'll have.
the plastic bags.
The
And you
plastic
can use
bags.
anything. I mean, you don't have to have the commercial.
No, like,
We've used an Ambu bag before.
Yeah.
yeah, if you've pulled some equipment out of a plastic bag, tear it open and use it. Wrap their body in it, not their heads.
Not
Wrap their body
their
in
heads.
it. Put a hat on. You're at mama's house, you ain't got a hat, grab a sock out of her drawer. Like, something to keep that head covered, keep that heat in.
hmm Make sure they're dry
Yeah.
as
not,
best you can.
And not tinfoil. I've seen that happen. Don't wrap
Aw.
a baby in tinfoil. I've
Unless
actually
you-
seen it.
Unless you've got
I've
the good
seen it.
tinfoil like blankets that are made for that, but
Yeah, the-
not
The emergency blankets, not just
Yeah,
Reynolds
not
wrap.
some Reynolds wrap
Not
out
some
of the
Reynolds
bottom
wrap.
drawer in the kitchen.
my little burrito from Chipotle. Oh,
Yeah.
All right, working down to the A and the B.
A and the B. A is airway,
Anyway,
Okay, we've already talked about that pretty
We
bit.
have.
B is
blood pressure.
blood pressure.
Blood pressure, yep. Yeah, blood pressure. So we kind of talked about that. I mean, normal salinine's what we use, 10 mils per kilo per bolus. Sometimes we'll do 20, depending on what the
Yeah, situation. I mean,
situation.
if you've got a baby who, mom had placental abruption, there's some kind of big hypovolemic insult there, then you'll probably go with a higher rate for or higher dose for your
Yeah.
saline bolus, but usually it's just 10 per kilo.
Yeah. Babies less than 30 weeks go slow. Slow. Do not, I mean, it seems little. A 500 grammers, 10 per kilo is 5 cc's, a half of a flush. Like, that's nothing.
And when you say bolus to, like, adult people, you're like, ram it in. Don't.
Squeeze.
we have syringe pumps. We have pumps. Everything we do in neonates goes on pump for
Yeah.
the most part.
Yeah. So if you can give that bolus over 10, 15 minutes, 30 minutes for smaller babies, in a code, that code's
Yeah,
going to be
code
over. But
situation, is a little different, but you
Still
still,
don't just-
I think NRP says 10 to 15 minutes
Mhm.
in a code situation, but yeah, you're on the back end and you're just more stabilizing now. Take it slow. Take your time.
'Cause they'll bleed. Their
So
heads will
what?
bleed.
So what is a normal blood pressure in a neonate?
Great question.
Wonderful question.
Usually we try to have a mean blood pressure of around the gestational age.
So I got a 34 weeker. My blood pressure mean should be
34.
Da-da-da. 23 weeker, mean blood pressure, 23.
So easy to remember.
It is. But again, don't hang up on that.
Right.
Too. So if you've
if
got
you got a 36 or 35 weeker and his blood pressure is like mean of 30, it's
We're
okay.
okay.
It's okay. If we don't have anything else pointing in like, oh man, this baby's about to tank, then
let it be.
let it be. Yeah.
Diastolic
give
of
'em
2
time.
is still bad.
Oh, don't love that.
Don't ever love
Yeah,
that.
don't love that.
I remember one time we went somewhere. Had to go for tangent. They're like, oh, well, the mean's 34, and it was like a 32 weeker or something, but the diastolic was 2, and they repeated, and that's still like 2, 3, 4. I'm
I
like,
am impressed by the blood pressures that the Zoll picks up.
Ooh,
Can I just say that?
Yeah.
Because
Shout out
our
Zoll.
monitors, like, it just be question marks, and you're like, oh man, That thing will pick up a diastolic of
Seven.
seven.
Yeah.
Like, you're like, whoa.
I'd
We used
rather
to have
see
to
the
pull
question marks.
We used to have to pull the Dynamaps out in the unit
Yeah.
to get blood pressures that way.
Yeah,
So,
I'd rather have the question marks than the means of 7.
please. No one wants to see that.
No.
So we talked about dopamine. We talked about boluses.
Yeah.
Slow. That's the big thing
Slow
here.
and steady.
So sugar, temperature, airway, breathing,
labs.
blood pressure, labs.
Everybody loves labs. Okay, so Stable talks about labs with the CBC and kind of watching out for infection. CBC is great to have on babies who are born in places that they shouldn't have been born, and if you have got risk factors for infection. So I'm not saying every baby needs to be on antibiotics and all that too, but if you're getting lab work, go ahead and just grab a CBC too to get a good baseline. What's great about that is the same thing with adults. You can see whether or not babies are showing signs of infections with the CBC. For us, it's not necessarily the white count. Babies will have elevated white counts right after delivery anyways because the stress of being born is so much on their bodies. What we look at is the differential and for all the immature cells. So that's kind of what's with Stable. They're looking at with the labs and the immature cells and whether or not there's been a shift there. Mainly for us, lab work that we like is the blood gas. Everybody makes fun of us for that, but we love a blood gas on these babies.
Yep.
They're it's so telling.
It really is.
Because a baby, like Lauren said, you'll have a baby just looking at you smiling with a terrible, god-awful blood gas. They are fine until they are not fine.
Yep.
And so blood gas is a great way to get clues. So if you're sticking a baby for a blood culture, because a lot of times they'll art stick. Some people will art stick and for a blood culture, but they won't get a gas. Just grab a gas if your baby's on respiratory.
Especially, you have any kind of respiratory modes in place on these babies, get a gas.
Mm-hmm.
I mean, it's just like a good baseline. Same as the CBC, it's a good baseline to have just to kind of know where you're going with where you are.
And especially if the baby's had a neuro hit. So you may even have a very stable baby respiratory wise, but if mom's abrupted and the APGARs were low, but he's kind of turning around, get a gas then too, because that'll show you a good metabolic clues that can maybe help us further on with the care of the baby. So blood gases are really important.
Yeah.
Cab gas, venous gas, art gas.
All the gases.
All the gases.
I mean,
art gas is like
gold.
Yeah, but I mean,
They're hard.
Yeah, they are.
If you get a good IV that's draining and you try once for an art gas, just stick with the venous.
Yeah.
Oh, and it's hard to pull back lab work from our IVs too.
Yeah,
Our catheters are so small they collapse. It is hard to get blood out of there. I'm gonna say even if you've had trouble getting that IV, don't mess with it and pull back blood on it.
Yeah, you don't want to mess up your IV.
And the likelihood of it actually pulling back like that is so low because that catheter's so teeny tiny.
Yeah.
Cap gases are fine. I mean, you just know that depending on your technique, it may be a little bit skewed.
Mm-hmm.
When you heel stick a baby, it is the pad of the foot on the heel.
On the heel, yeah.
A lot of times we'll say finger stick just out of habit, like a finger stick sugar. I mean, that's what everybody says, but it's not a finger stick on the baby. Yeah. So, yeah, the heel of the foot is where you're shooting for with blood work. But, yeah, that's really it with the lab work part of it. I mean, of course, it goes into more detail, but the nuts and bolts of it is labs are important for us. I mean, in transport, a lot of times we get in the mode of scoop and go and let's just get back. But, you really can do a lot of great things to improve the care of the baby if you do get some baseline labs and get some care started on the front end versus delaying it.
Yeah.
All right, we've got through everybody else but E.
Emotional support. I mean, the main thing with that is just being empathetic of the family of that situation. So that kind of goes back to that viability discussion.
Empathetic and honesty.
Yeah,
Just
100%. And that, we're taking the care of this patient, but this patient is somebody's little baby that they just birthed and they had been anticipating, hopefully waiting for 9 months, sometimes less. And a lot of time we're scooping up this child and leaving and not even giving them a second to see this child. So I think, that may be the only time they see their baby alive. So, I mean, I can't spend hours with these families, but I think, really remembering that this baby is a part of someone's family and that you've got to have respect for that. You've got to respect their wishes. You've got to, I don't know. And it really does help with bonding with the child too. I think, like if they've never seen this child and then they're laid up in this hospital hours away for 2 or 3 more days, they miss those key moments in that baby's life for those first 2 or 3 days. They get there, this baby may or may not be doing well. And if it's not doing well, you've never really connected with this child. The baby may or may not pass away. And then, I just can't imagine what I can't imagine how they feel during that situation. So I think what's really important, and I think that goes for any patient we transport, if there is family around or if there is anybody around that is a part of this patient's life, you should take a second and just make sure.
Take the 2 minutes and explain, hey, this is what's going on. This is where we're going. Y'all do an awesome job with this. I mean, I'll brag on y'all as a team. Every one of y'all takes the 2 seconds, whether we can or cannot.
Yeah.
I mean, I remember me and Lauren did one a long time ago that was, we literally couldn't. We didn't have the gas. We were on nitric. You were on every little thing. And we're like, all right, look, we got to ruin the aircraft in the first place. We're on the coast. I know. And so you went and talked to Mom and explained everything. And then I went back and like, all right, look, we're going to wheel this in here. Literally just do a drive around the bed.
Just come right through by the bed and right out.
But taking that 2 seconds can make a big difference in their day. It makes a difference in the family's day and everybody in the room, not just Mom or Dad, but grandparents, cousins, aunts, whatever.
Yeah. And it's a scary situation. I mean, babies, I think, you don't, a lot of times, I didn't know anything about sick babies until you start working in the NICU. You know what I mean?
Oh, yeah. You get, nursing school, paramedic school, whatever, you do, you get like all these adult and, diseases, and you get this little splash of babies thrown in there where you kind of hit on
a solid 2 weeks. Here you go.
Not hit on like the more common things, but just a little bit, just so you know enough. And then when you start working with these babies, you're like, whoa, what? They can do that? Like,
oh yeah, it's scary.
It's insane.
Yeah.
It's literally on the job training. Like,
and so unless otherwise we're walking in and you've got this isolette with all these things beeping and you've got a ventilator and you've got all these things connected to this child. That is terrifying for the person who hasn't had the ability to see this every day. So.
Even like, we go all over the state of Mississippi and you pick up patients, babies and their parents are physicians or NPs or nurses or what have you. And they're like, high quality ER, ICU, really, really smart people. And they're like, I don't have a clue.
Yeah.
Like, can you explain this to me?
Yeah.
But taking that 2 seconds to explain it can really make a difference. And
you may not know the answers. They want to know exactly what's going on, and sometimes these babies
we don't know.
We don't know, but at least letting them see their baby and letting them, or at least giving them the information you do know, and just I don't know. I can't imagine being in their situation. But E is emotional support. That is it. I mean, it really is important, and you kind of make fun of that part of Sable. It's like, okay, we're talking about sugar, airway, da 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 da.
Yeah.
Emotional support.
But emotional support is important.
It is important.
Because, that's someone's child.
Yeah.
Or loved one and someone's baby. And I don't know. You've got to remember that part is just as important. And it seems silly to talk about when you're talking about intubating and you're talking about blood pressure management and you're talking about all that. But this may be the only time they see this little baby alive.
Yeah.
Moving on kind of there, we hit a couple other things I wanted to talk about, but vent and bagging, because they're so important and these kids are all airway driven. So if you do it right, it's great. If you do it wrong, they get catheters in their chest and it's a fun day, or they get hypotensive and their thoracic pressure, or big things with me. I wanted to talk about real quick. How likely are y'all to put an OG tube in somebody?
An OG?
Yeah.
Oh yeah, very likely.
Every one of them almost.
Yeah, you got to decompress that abdomen.
So it's something about, for those of you pre-hospital, do you have an OG tube the right size? Do you have one available? Or even small ERs, do you have the right size? 8 French, 5 French, whatever it may be. But if you're having really trouble bagging a kid, think about, well, maybe I need to decompress the stomach, and that's a simple thing.
Yeah, I think we talked about that a second earlier, but that'll play a big role. That abdominal distension, push up on that diaphragm, and you're just making your respiratory issue worse. So yeah, that's a big thing to be mindful of. And you're not really thinking about it in the moment where you're trying to bag a kid, because you're bagging a baby. This is not how you wanted your Tuesday to go. So, that's not one of those things that are at the front of your mind, like temperature. But it really will help you out and help that baby do a little bit better.
As far as bagging kids, manometers.
Oh, love a manometer.
Yes.
Get a manometer. Get a manometer. Get a manometer. Get a manometer.
So what pressures, we talked about how kids are driven by pressure, and it's all about pressure when bagging a kid. What pressures are y'all shooting for?
20 over 5.
20 over 5.
That's good baseline. The smaller babies, you of course.
Is that a total pressure of 20, just to clarify this?
Total pressure of 20.
PIP
Yes.
20.
Yes.
Okay.
Smaller babies, of course, can get away with less, 18 over 5. And if you're using a T-piece resuscitator, you can set that on the nose and do 18 over 5. It is hard to hit exact pressures when you're bagging.
Yeah, it is. But you can get,
But if you're kind of mindful, okay, I've got a 23-weeker who maybe doesn't need 20 over 5. So then once you're starting off with that 20 over 5 and you're watching that chest rise, you can maybe back off a little bit and go less.
Yeah.
Sometimes you're fine with 15/5, but just a baseline start on every baby. We start off at about 20/5 and kind of just go
and just
from there.
judge from there. If you've got crazy chest rise, back off. If you don't have much, add just a little bit more. Not like don't go up crazy on your pressures, just 1 or 2, and then see where we are. Because you're likely to pop a pneumo, and then that's a whole nother
whole other bag, whole other problem there.
Yeah.
Real fast, because a lot of people, if you've never given surfactant before, and
It's a miracle drug.
My magic
it's
drug.
magical. If you've never given surfactant, bagging surfactant in.
My favorite.
Talk me through it real fast.
So surfactant is a wonderful drug. It is one of those that you can see work, and
Yeah.
it's amazing.
Yeah.
So when you're given surfactant down your ET tube, your number one thing is you want to get an X-ray.
Yes. Preach.
You don't check for placement with an X-ray, but you check for depth. So we're looking to make sure that we're not right main stemmed, because you give all that CureSurf down your right main stem, you've not done anything. So
You fixed the right. There's the left over
but
here.
this
It's
left
just
is really
left
going
is
to
totally
really
disappointed.
It's
Yeah.
really going to make you sad. Yeah, number one, get that chest X-ray. Make sure you got good placement. And usually we warm CureSurf. When you give it, it's good to have an extra hand with you, somebody who can give it and someone who can bag it in. So whenever sometimes the volume can be big depending on how big your baby is, because it's like 2.5 mils per kilo of CureSurf that we give. So sometimes your volumes can get a little big, so you might have to give it like an aliquots. But get you a friend at the bedside and one of you give it. Usually they say head midline. Some people like to turn on left or right. Usually midline's going to be your best bet. Slow side breaths, so just a long breath and
long inspiratory phase, just slowly in there.
Yeah, just like a sigh breath. And a couple of those, you can, if you have more to give, you can do that. Not pop them back on the ventilator, give them a few minutes, and you can just watch that. The sats come up and that FiO2 go down. It is
magic.
It's magic to watch.
That is
it's
my
so
favorite
cool.
drug to give.
Yes.
And watch your pressures afterwards, because you usually can wean your pressures because they get so much more compliant.
Yes.
You can
start
wean your
at-
ventilator.
Chest
Yeah.
really
You
move.
start at 24 or something ridiculous. Hey, I can't get this baby to ventilate. I can't get him to oxygenate. I remember one man you did. They were on 28 over something, 28 over 6 or 28 over 8. And we're like, this is not good.
And their chest wasn't even moving. Though.
No. They were just... So we gave surfactant, and all, but we're down to 18 over 5, and we're chilling. And
go slow with it, but yeah.
Yeah, I mean, like, by the time we're back home, it's like, all right, everything's hunky-dory. Well, I thought this baby...
No, he just needs some surf.
Just need a little...
Needed some surfactant.
Yeah, just make sure that after you do that, you try to wean if the baby responds well. Now, if he doesn't respond well, don't be like, hey, I gave surfactant.
Yeah, I guess
everything's
so I
gone.
can go to 21% and no pressure.
Yeah, no, go slow with your
Go slow
weaning if
wean.
you're able. If you see that chest rise improve, or if you're able to get a gas and see that, okay, now I'm overventilating, make your changes.
Yeah.
Because they will change quick. Like Lauren said, it's a magic drug.
It is. It's awesome to watch.
That and nitric, my favorite, and vecuronium, but that is just because you can immediately see it happen. I don't love it otherwise, but I just do love the immediate, like, oh, that works.
I'll spare you all the nitric conversation. We can do that on a different day.
Yeah, that's a whole nother
That's a whole
That's a
Yeah,
day,
well-
that's a podcast, that's a dissertation.
It's a series.
Real fast about transport considerations, because a lot of people don't understand what we do.
Yeah.
They don't understand. Okay, why do you fly? Why do you drive? Why is there an EN8 team? What does Isolette do? All these, that fancy pizza box. What the heck does it do? Talk a little bit about transport. What makes you go fly? What makes you drive? What's important considerations y'all have as far as making those decisions or making the transports happen every day?
Well, I think one of the things you asked about, like, why do we exist, essentially? Like, why is a neonate team necessary? And I think it's just because we deal with such a specific population that, you can get all the education. And I think it's great to provide that education. I think everybody should know what we do. I think that everybody should. But, unless you're doing it every single day, or that is the only patient that you focus on, I don't know if you'll necessarily be as... I don't mean to say that we're like experts in the field by any means, but like I think having a specialty team work on that specialty really is important for that patient subset, I think. I mean, like, it's just because a lot of the things that we see is not stuff that is in textbooks or anything like that. It's because, I've taken care of this baby X, Y, and Z many times, and I've seen how they react to this, so I know that in theory that this one should react the same way. Or this is not going to work because I've seen blah, blah, blah happen. So I think that's what's important about having a neonatal team. But again, not necessarily that we have to like hold all of our information and we don't want other people to know it, because I want everybody to know it. But I think that's why we exist, at least, or why, because it is just such a specialized set of patients that is just, unless you get to do it every day, I don't know. I mean, how long have we been doing this? I know over 10 years. Mm-hmm. And there's still patients that make me so uncomfortable. I'm going to tell you, every time I patient, like, every time we get toned out.
Yeah, you still get, like,
nervous.
The little rush of, oh my gosh, what is this one going to be? Like,
yeah, and so I think with us, and if we're still feeling that way, I can't imagine not doing a patient like ours every single day and then being thrown into, oh, go get this baby who's got blah, blah, blah happening, and feeling confident in it. You know, I think with us, we feel we have some level of confidence because we know the basics, but as far as feeling like
every little weird disease process it presents, you're never going to learn it all, right? It's constant learning process.
You learn something new every single trip.
Day.
So and that's us specialized. I can't imagine knowing all the things that everyone else has to know about with adults or with peds, and then on top of that, being really competent in the neonate side, because they're so different. The baby side of it is like weird little science. Like, it is anything you learn in nursing school or paramedic school or med school is completely opposite in kids.
Yep.
Or babies. But okay, so that's why we do that. What else did you ask?
What, flying and driving? What?
Go for it, girl.
I don't know. I don't want to say preference, but
down the street, we're probably going to drive. Let's just.
Oh yeah, you kind of look at everything, distance, what's going on with the baby, what kind of facility the baby's in.
Mm-hmm.
If you've got this super sick kid, but it's at this hospital that's an hour and a half away with a neonatologist, you're less likely to be like, oh my gosh, we've got to fly there. Like, we've got to get there right now. Unless it's something like surgical. Those are ones that we kind of want to get back pretty quickly. Anything that's surgical abdomen, heart defects, cooling kids.
ECMO.
Yeah, ECMO, things like that. You want to, we try to fly those when weather permit. But otherwise, we just really, it's a couple of things that we look at. Just how the kid's doing, who they're with, where they're at. So.
Yeah, it's always sexier to fly. Do you know, like, everybody thinks, oh, you're on the...
Oh, that is so cool that you...
Yeah.
Yeah.
Yeah, it's cooler. It's not.
Sweaty, and it's...
well, yeah, personally, it's not. It's hot. I get sick.
Yep.
But the babies a lot of times don't tolerate it.
Like it.
And so, I mean, you got to take that into consideration.
Yeah. Some babies do great. They just pass out. They fall asleep. This is like the best chill ride in the world.
Yeah, and also, I mean, you got to think about what kind of day it is. Are we IFR? Are we VFR? Is this baby that's got a perforated abdomen is not going to like being at a higher altitude. That's going to almost kill that baby. Mm-hmm. So, like, those are things you have to take into consideration, too. Yeah, they need to get back, but we want them back alive. We want them back doing,
that's part of what I want to talk about. Even the respiratory kids that are on nitric that you can't get their SATs up, their SATs are holding in the 60s or 70s, no matter what we're doing. And it's like, this kid probably needs ECMO or something. Yeah. There's something going on here that we can't immediately fix. We've all the dental surfactant things and all the things. And that altitude change going from, 100 feet off of a pad to 1,500 feet, that their SATs drop 15-20%. They can't tolerate it.
Yeah, Lauren and I just had that baby like 2 or 3 weeks ago. It was a nitric 100% sick baby, and we had the option to fly.
Yeah,
but we elected not to because the weather, it was terrible out. We could have flew, but we knew it was going to be turbulent. We knew that we'd have to be at a higher altitude, and that baby, now you put yourself in the situation, now I've got to manage that baby for maybe an additional hour or so. But if you kind of weigh your risks and benefits with that, okay, we've got the equipment to do that, we've got the skill and the knowledge to do that. Yeah, it's longer, and you're technically making more work for yourself because you're with the patient longer, but the baby does better.
Outcome is going to be better.
And that baby did really well with us. He did really, really well. And so I think there's a lot of reasons why we will fly or drive, but sometimes it is just kind of intuition and personal feeling about what you think the baby's going to do. Now, sometimes we get it dead wrong. We get it so dead wrong. You
feel so bad.
Oh, yeah.
I was going to put a plug in here for MedCom because MedCom helps kind of coordinate all this stuff on the backside of it. But, like, if you guys get somewhere by ground and you're like, not happening, send me an aircraft, and it will send, whether it's 1 or 2, 3, 4,
Yeah.
anybody with an isolate.
Yeah, and then vice versa. They're like,
Yeah.
oh my God, this baby is so bad. You got to get here. You got to get here. We get there, and you're like,
He's sucking on his
really?
passy.
He wants a bottle.
Yeah.
Like, what? You just took this aircraft away from somebody who could have needed it.
Yeah.
But,
Sometimes
so
we get it
works
wrong.
both ways.
Yeah,
Yeah.
we get it wrong sometimes, but you just
Or they tell you, it's whatever diagnosis. And you're like, oh, I know that's going to be bad, so let's go. And you get there, and you're like,
we've
Man.
been bamboozled.
bamboozled.
But at the same time, it's all based off resources and what you got
Yeah.
available, and it
Yeah.
may be the right thing. Or there's been plenty of times we've done 4 or 5 neonates in a day.
Yeah.
Oh,
Out
yeah.
of here, and it's just like, all right, the reason we're flying is just we have the volume.
Yeah, and we just physically cannot do it with, and I think with us where we're different from other programs, some places are dedicated peds neo teams, and I think what is important to know, like just with our program, we're not, and so if we, I hate to say the word like misuse our resources, but if we aren't quite right with why we decide to fly for our situation, so. I mean, we joke about it, but like if I get up 3 hours away and I've used that helicopter for an hour, well, 3 hours drive, but hour, whatever. I'm saving time by getting there, but in the meantime, when I get there, the baby's sucking on its passy and doesn't necessarily need me. And then there was a 10-car pile up here or somewhere where that aircraft could have been utilized.
Yeah.
Then it's like, shoot, I just took away that resource from those people. So we do think about that part of it too, but that is kind of a difference with us. We don't have our own helicopter, so that is something that we do take into consideration, that we've got to be just mindful and cautious of that as well. So that's something that we consider too. We really do try to get it right when we utilize the aircraft, but everybody looks at us and they think, oh, you fly, it's awesome, da, da, da. It ain't that simple.
Yeah.
There's a lot of stuff that goes in the background about what's going on with it, whether it could be simple things like, hey, this kid, I know Pease does it, they have a Vapotherm, and they like to use it for high flow for their asthmatic
they do great.
kids.
That
And they'll put them
saves
on
their kids.
Presidex, and they're like, hey, I mean, we do high flow in the airframe too, but if a kid is the worst case scenario, kind of get off subject, but if you have an autistic kid that's an asthmatic, autistic kids in an airframe are very challenging.
Oh, I can't
yeah.
imagine.
So if you can get them in an ambulance where they can have mom next to them and they can kind of be a little less stimulated, and then they're on top of that, they have a Vapotherm available. I mean,
that Vapotherm is a game changer for
It
them.
really is.
So it's, again, there's a lot more that goes in the transport world, a lot more decisions about flying, driving, what have you, what's going on with them.
The isolate.
Somebody's coming. It's just how we're getting there. How we're getting there. We may get there real quick and come back real slow, or get there kind of slow and come back real quick.
Yeah.
But somebody's coming some way.
Yeah.
Yep.
Yeah.
All right. Well, I appreciate your time. Thank you for sitting down.
Oh yeah.
Shameless plug. I'm going to get y'all to do it again on some other things, but we'll spare you the nitric today.
A whole podcast series.
Yes, a whole
Emily,
series.
Lauren, Will, and Nitric.
All right. Appreciate your time. Thank you, guys.
Thank
buddy.
you.
This has been a presentation of Blue Crew Medicine.